welcome to Let Them Talk. I'm Paul DeRienzo.
And I'm Miss Jo Marie Musi.
And our guest, Dr. Sunil Aggarwal.
Hello.
Joining us, and we're going to be talking about medical marijuana, which I'm looking forward to. This is, often we've had a lot of guests talk about medical marijuana, but a few times that we had an actual medical doctor talking about it. So, and that's something that's hard to do. I think most people in the medical profession want to stay away from something that's not based on science, really, or.
What they think so.
Yeah.
A lot of uneducation and a lot of training that's been lost, and so we have to. A lot of doctors are afraid to talk because they don't know.
Right.
So there's a lot of educating to do and bridging to build.
Is it studied more in states where there's legal marijuana, where a doctor can prescribe it?
Well, it's starting to be. There's more continuing medical education courses in a lot of those states. There's a lot more efforts to try to have events at medical schools and grand rounds, presentations. I've seen a lot of that happening.
What about the issue of self-dosage? When you prescribe medical marijuana to somebody, whether they have a tincture, or eat a cookie, or smoke a joint, or smoke with a vaporizer, they're pretty much deciding their own dosage, aren't they?
Well, first of all, let me correct your language. We don't actually prescribe medical marijuana in these 17 states now that have these programs. I've seen about 3 of them in operation in Washington, Oregon, and California. Technically, it's an authorization or a recommendation. And why I make this distinction is because prescriber power, especially for this class of drugs, the federal government has decided to sort of usurp to itself or whatever, regulate to itself. So states can't allow the doctor to actually write on a prescription pad, but they say, look, you're able to use your medical judgment to make a determination that this patient may benefit from this drug, based on certain condition lists, that kind of thing. But then when you're with that patient, you have to make a decision. Okay, is this, in your opinion, do you think this patient could potentially benefit from this botanical medicine, which is what really cannabis is? Right. Marijuana is technically what I called in my research is a cannabinoid botanical. That's technical speak for the chemicals in cannabis, the phytocannabinoids that interact with our own bodies, endocannabinoids, which I'll get into a little bit later. But so when you ask a patient or discuss with them about dosing, the proper usage, and I've written papers with some colleagues about dosing paradigms, is that you follow a route called auto titration, self-regulation, because the drug is so remarkably non-toxic. And that's the key thing that separates cannabis from aspirin, from other
morphine,
certainly opioids, opiates, is that the toxicity is so low. So that allows
so there's less risk of allowing a patient to make decisions for themselves.
Correct. That's one very nice thing, because the number one rule in medicine is do no harm, right? There's a lot of harm that's done with good intention, but drugs carry a lot of risks, and that's.
Now, as a doctor, you're saying that marijuana has low toxicity. However, just in the last few weeks, several politicians have specifically said that marijuana kills.
Who said that?
Politicians say that all the time. They do. They say it all the time. And the Partnership for a Drug-Free America and a lot of people in the administration, this administration and previous administrations, they have no discussion. They think you're out of your mind. Marijuana kills. All right.
Yeah,
many people believe that. I think
but
millions
can you name
of people,
anyone who died?
especially in authority, believe that. And how did we get to that point? And why is it so hard to get the truth out to people?
Yeah, you got to dial the clock back to the, starting from the 30s to when the original federal bans were put in place for cannabis, where the government actually had to hire a pharmacologist from Temple University who testified to Congress that the use of marijuana in his research in dogs, this was done at Temple University in Philadelphia, he said that it could cause the dogs to go insane. And then he went on to testify in actual criminal cases, this pharmacologist, his name was Dr. James Munch, that the use of marijuana, in one case somebody said, okay, sure, marijuana makes you go crazy, and they use it as a defense against the crime of murder. Somebody said just being in the room with marijuana was enough to get the vibrations of insanity, and this pharmacologist testified as an expert witness that yes, that's possible.
Wow.
And he said in his own research, this is all on record, that he had.
Is that possible?
No, it's absolutely absurd. Certainly. people can create myths and fears and taboos around things and can drive themselves into a tizzy over something like some symbol. Like some people might get upset if they see a certain symbol that they know, but it's nothing to do with the pharmacology of the substance or any of the chemistry. It's all to do with our psychology.
Sure.
But this doctor actually testified in court that he had used marijuana in his research and that he turned into a bat. And he flew around the world and landed upside down in a vat of ink. This is the official expert, federal expert. So that's how long back some of the distortions, the scientific distortions, go on cannabis. So I've actually researched the congressional record and I found all this documented.
Okay. Wow. So this is actually how. So, but yet, why is it so difficult to confront this? I mean, we don't. Well, they give leeches to people now again, but for actually a good reason. In the past, they put leeches on people for a long time, but we stopped doing it. I mean, what's wrong? Well, how come there's no advance here? How come where's the disconnect between science, the truth, and what the government is saying?
Well, you're absolutely. Bloodletting was really more what was going on in the old 1700s, and some of that medicine was. We're glad it's gone because toxic heavy metals and things like that really ended up with a lot more dead bodies than cures.
Right.
But what we're talking about here is an old medicine that has a much longer track record cross-culturally and historically, and modern research has basically helped to confirm a lot of the
and a record of being effective for people.
Oh,
because one thing that interests me of the different patients that we've talked to on our show is that a lot of them say that they were on heavy pain medication and were able to change to just smoking relatively small amounts of marijuana.
Yeah.
How can marijuana substitute for like an opiate painkiller?
Well, basically from 1830s to like 1940, marijuana was available in pharmacies throughout the United States and Europe for treatment of pain syndromes. We knew about it. Opioids like morphine did come along and eventually did, because of the politics around marijuana, but also because of the ease of solubility of opiates in water solutions, whereas these cannabinoids in cannabis are fat soluble and they may not have had the same stability sitting around in the pharmacist's shelf in their hot temperatures without air conditioning or whatever it might have been in the old days. So there was always cannabinoids or cannabis and opioids like morphine, heavy narcotics, available in pharmacies. But eventually one took place of the other because doctors became afraid to use cannabis, and because opioids became, you could inject them with a hypodermic needle.
Bingo, it's over.
It's like rapid, and really that's what happened. It sort of just fell out of the utility. But it's not the case that it wasn't relieving pain. And in fact, the father of internal medicine is named Dr. William Osler, actually Sir William Osler. He's from Canada. He started the first rounding in hospitals at Johns Hopkins, and his textbook of internal medicine, his first several editions, said that cannabis was the most effective treatment for migraine headaches. And that textbook is still actually in multiple editions. It's still being published today. So doctors knew even back then that cannabis had pain-relieving properties, and we've just become so opioid-centric because we lost this very effective treatment in our pharmacopoeia. So we're surprised that, wow, it can actually also relieve pain. And it turns out the system in the body that it acts with is independent of the opioid system. And there's actually 10 times more receptors called cannabinoid receptors in the brain than there are these opioid receptors.
Oh, that's
Do we know how marijuana works? Do we have any idea how it works?
Yeah, there's a lot. We're getting a lot more. I mean, back in the days of Prohibition, Reefer Madness, people knew nothing. They just, it was one theory up until really 1990, people would still, or 89, 88, somewhere in there, people would still think that it would non-specifically go into your cell membrane and just sort of roll around in there. But that theory was basically
that there was no receptors for it.
Exactly,
because to say there was a receptor was to say there would be a natural, and then what they wanted to say, the anti-pot people wanted to say this was an unnatural addition. If there's already a receptor for it in the body, then it's not unnatural.
Well, certainly
it's not like a communist infiltration, right, of your cells.
That's right. It's the demon weed.
Which is how they used to think that way. I mean,
that's right. That's exactly right. I mean, but the fact of the matter is, this system has been in evolution for 37 million, or actually 600 million years. Cannabis sativa, the plant that produces these chemicals that happen to interact with that system, that's about 38 million years old. So it's a young plant, but it has been able to this is what plants do. They come up with these really great chemicals that are defenses for their own needs. This plant was probably making these chemicals to ward off against UV radiation from the sun, or
THC protects you against UV radiation.
Yeah, the plant does. Yeah, that's why you go higher in altitude. Cannabis is now widely all over the world now growing, but as you go higher up in altitude, there's more direct UV, and there's tend to be higher concentrations of these cannabinoids, which is
that's
the
what
resin.
gives you a suntan and a sunburn, and you want to avoid too much UV. It's cancer causing.
It can, yes.
And it can destroy plants, and so you need a protection against it, a natural protection.
That's right, and also like insect, they have to ward off against insects and predators, and that's what plants do. They got to survive, and they're very good at it. So it turns out sometimes they make chemicals that just so happen to bind into the system of other creatures that come around, like human beings. And
because we're all made of DNA in the end anyway.
Exactly, we're all chemical, we're all genetic cousins, if you go back far enough. So, so that's what happened. Cannabis turned out to make chemicals that just so happen to work quite well with our system. And there's been a really harmonious relationship. Well,
so predatorial animals and insects would stay away from marijuana because if they ate it, they would become even hungrier.
Well, now, it doesn't generally always have the same effect.
I just had to tell that.
Because you actually have to decarboxylate, you have to activate those cannabinoids with heat, and that's what we do in our production of these edibles.
So getting high, what is getting high all about?
Well, what the research has shown...
Why do we get high?
Yes, well, the research has shown, and if you look at sociology work from the 50s and on to, there's a whole field called social pharmacology. Most of drug effects, especially psychoactive drugs, has a lot to do with expectation, set and setting. So really getting high, getting blissed out, or whatever these things are, more or social constructs as much as they are chemistry. It's not about the drug. The drug it plays a role, but it's so much also our expectations. So, for example, cannabis was in medicine for 100 years, like I was mentioning. There's not a whole lot of accounts from the United States about people describing, listening to cello concerts or whatever they might have, classical music, whatever the equivalent to relaxation, listening to music and getting stoned with your friends or peers that you might see in the movies today, or what people might do. So it's because
they drank.
There was a lot.
They drank like fish in that era.
Well, there's still a lot of drinking in this country, but basically what happened was that people acquired this kind of idea that there could be a social custom or ritual around this drug, and that you learn an expectation that this can help you to relax. And it turns out that the chemicals in cannabis also interact with your stress axis, your hypothalamic pituitary adrenal. It's called the HPA stress axis. So, if you're expecting to have a stress relief response, the drug does help to facilitate that, and social expectation helps to do that too. So that's really what a high is all about. It's all about a combination of expectation. But when you're using a drug for a completely different purpose, I'm using this I'm going to numb my pain in because my pain is so bad in my foot. It's a burning sensation because the nerve is damaged due to medication or
my
disease.
psyche because I'm depressed or whatever.
Correct, sure, yeah. Mood disorders are a whole other lot of expectations too.
Opiates work good on those temporarily.
Right, it doesn't numb the pain, as you said.
For a while.
Psychic pain you're talking about.
Right.
And then what about specific diseases, like people that say that it helps with glaucoma or that it helps with MS or?
Yes. Well, that's the fascinating thing. Because we discovered all these receptors in the body starting in 1988, and then until 1994 we discovered the actual chemicals in our body that naturally bind to those receptors. We've discovered a whole system in the body that is called the cannabinoid signaling system. And it turns out that system is involved in everything, a lot of physiological functions: mood, appetite, memory, inflammation, nerve protection, bone growth, like I said, the stress axis. It's really incredible. So it turns out in several of these diseases that you've mentioned, there is actually a dysregulation in this endogenous cannabinoid system, where taking something like a phytocannabinoid, that is a plant-derived chemical, can help to restore the hyperimmune response. So in multiple sclerosis, your immune system is revved up and you're attacking your nerve cells, and you're having an autoimmune attack against your nerve cells. But the cannabinoid system, which is part of all those cells that's in immunity, can if you take a chemical from a plant that can kind of tamp that down, you can reduce that inflammation process. Spasticity in MS, pain. There's lots of studies coming out, large, multi-center, randomized, like the top shelf evidence trials that show with placebo that you can actually really show that patients who don't even know what they're taking and people who don't even know what they're giving them, end up having relief, and potentially, which is what's very exciting, is that you may be slowing down these disease processes. So,
really?
Yes, that's what's really something. We're going beyond symptom relief and palliation, which is very important, to potentially modifying neurodegenerative diseases.
So cannabis, marijuana, actually, besides just making you feel better, could actually have some sort of treatment potential or curative potential.
Correct. That's right. I've seen. There's case reports piling up. There's animal studies. We've been able to, for example, if you have mice who have a mouse model of dementia, Alzheimer's dementia, you can show that they live longer when they're taking cannabinoids versus the mice that don't. There's even cancer studies that have been shown, even in humans, that you can inject cannabinoids, which are these chemicals in cannabis. And it's not just THC. I have to tell your viewers that there's it's basically a plant pharmacopoeia. It's got a yin and a yang. It's got another chemical called CBD, cannabidiol, which is kind of like the anti-THC, and it blunts some of the worst effects of THC. It's an antipsychotic and an anxiolytic. And it turns out it's an anti-tumor drug too.
Oh wow!
Now, does pure THC, like that they give people for like Marinol, does this have this effect? Because there is a chemical pill that.
Yeah, what is the difference between actually using the plant and using a pharmacologically derived substance?
Opponents of medical marijuana have always put that pill up as something they could dose and we could follow it.
Unfortunately, it's not the same thing at all. And we've even done head-to-head studies where you compare, okay, let's try people with this single pill, let's try them with herbal cannabis, and you have to use 6 to 8 times the recommended dosages of those pills just to get the same appetite-stimulating effect that you do from herbal cannabis. That was shown in an inpatient study at Columbia University.
And are you against smoking, or what do you think about that aspect of it?
Delivery systems have to be improved for cannabis, and with opioids we have patches, pills, sublinguals, sprays, topicals, injectables, orals, everything under the sun. And that's because we've had all this industry and time to work on it freely in research and development. But with cannabinoids and cannabis, there's certainly a lot of social history of its use, but I haven't had a lot of chance for doctors and scientists to kind of play around with different methods of delivery, topical delivery systems. Now, lung administration is a very effective and fast, rapid onset way to get cannabinoids into the body, and it's very effective for symptom relief because you have onset within less than a minute.
And that sort of goes back to the self-dosage thing of that you can say, okay, that's enough, I'm hungry, or that's enough, I'm not in pain.
That's correct.
As opposed to a pill where it just keeps coming until that dose is
it's a delay for up to an hour or two.
And speaking of the smoking, the Schaefer Commission report, when they went to Jamaica and they saw heavy marijuana smokers, much heavier than almost anybody we know, except for maybe Dana, and no lung damage because they said it's not tobacco, it's not a cigarette.
Look, this guy who just today won the greatest number of Olympic medals in the history of the Olympics, back to the days of ancient Greece, 19 Olympic medals. There's a picture of him using a water pipe, a big, what they call a bong, that was all circulated on the internet. And who knows, maybe he seemed to have some knowledge and experience with that.
One of the high-tech methods of administration and delivery.
His lung capacity must be amazing, and he's able to, win gold medals continuously.
Absolutely.
And so,
why the reason why they don't kick people out of the Olympics for smoking pot is because they don't want to say that it helps you, right? Like sort of
that it makes you
more athletic, and it does actually, and it increases. This is what I did an article about this. I'm not a doctor or a scientist,
sure.
But your body absorbs oxygen at a higher rate, and so especially if you work out all the time and you're in very good shape, if you're not, you might pass out. That's the reason why sometimes people feel faint when they get up after smoking a big hit of pot, because their body's absorbing more oxygen and they hyperventilate a little bit more than they use. And it's interesting, right? And then they, so it's probably not a good thing to do before exercising. But if you are in good shape and you do it, your body can handle all that oxygen, and you're actually pumping more oxygen to your cells. But they don't want to say that it's a doping agent, because then people, it'll be like the Olympics saying, giving their seal of approval to it as a...
Yeah, I'm sure we should take this up with the Olympic Committee. This is all, we need to do a lot more research on the physiology, exercise physiology with cannabis. It turns out that the lung sacs, called the alveoli, we have shown in research in asthma studies at UCLA in the 70s that it does help to bronchodilate and open up those lung sacs. Yeah. And there was even, back in the early 20th century, there was a company that sold cannabis cigarettes for the treatment of asthma. So it's not like a...
Interesting.
We've never known...
The first inhaler.
Right,
the first emergency inhaler.
Now, I'd like to ask you an ethical question.
Yeah.
Like, if you consider that this is something that will help people, that you believe it'll help people, what do you think about the people who have underground clubs for people in states where marijuana is not legal? And what is your opinion about that?
Basically, what's going on is, because of the federal government's intransigence to recognize the medical utilities of this plant, states have had to do what they can to stopgap this situation. I mean, we've had so many buildup of evidence, and so many expert commissions and so many clinical trials that all recognize, yes, there's medical utility here, and there's a great potential, and we've known for a long time. So what are people going to do? We're going to wait for that, finally, for somebody to have their aha moment in the administration, because basically
people are suffering right now.
Exactly, right. That's the problem. And we basically put drug control, we politicized it so much during the Nixon era, and scientific, clear-headed, even-headed analysis will not carry the weight. It's a political decision made by an appointee who's elected at the ballot box, who doesn't have a medical education or medical training. So in the meantime, while we get
that's what they used to say about us. You don't have any medical training, and you don't. Now, how about is marijuana addictive at all?
Well, I mean, addiction is a complicated concept, but I mean, the Institute of Medicine says 9% of users who use marijuana will become addicted or dependent, but then it does depend on how you define that, and it may be the case that a lot of things that we do, like iPhones and computers and electronics, have addictive qualities, so people may have some...
You can be addicted to anything.
Well, I mean, I wouldn't go that far, but I do know that there have been shown studies that show there's some sleep disturbances that you can pick up on EEG, some irritability, anxiety, these kind of things. But the nice thing about cannabis is that when it clears from your system, it slowly clears. It's called an auto-withdrawal again, because it's fat soluble. Right. It clears out, as opposed to something that is in there and goes out real fast. So if there is any physiological withdrawal or adaptation, it's really minimized because of the slow removal. And that's very nice. And
so it's a fairly safe drug. I mean, it's not, nothing's perfect in this world. Nothing is perfect.
No, I mean, every drug has risks and benefits, and Institute of Medicine has said that this drug is within the range of risks and benefits of other drugs that we use in medicine. So that's really not an issue anymore.
How would you put it into the context of herbal medicine in general? Like, I don't know if you know Susan Weed. She's an herbalist in upstate New York, but she says that herbal medicine is the people's medicine, because plants are available to people. They can learn about it. They can dose themselves and decide what's going to work and not work for them. And where would you put marijuana in there? Is it just like any other herbal medicine, or is it a particular special category within herbal medicine, or is...
Well, I know that people are working on things with the American Herbal Products Association to try to get that industry to buy in more to the medical cannabis movement. I think there's a lot of interesting progress going on with these groups, is what I'm hearing about. So certainly it's been part of herbal pharmacopoeias. If you look at Indian pharmacopoeia, if you look at Chinese pharmacopoeia, it was right along there, and oftentimes seen as like kind of a very unique plant because of its wide variety of uses. But cannabis really does fall into so many different categories. You could at one time see it as a people's medicine and home production or local groups, and versus something that you could extract and put into a spray or pill and a metered dose, and which pharmaceutical companies are doing right now as we speak in New York in clinical studies and around the world. It really has all that versatility, and I don't think that one development goal should be impeded by any other. I think they should all be allowed to go ahead because it ends up having so many uses to so many different people. Medicine is a cultural thing. How you take medicine, whether you like to go to your doctor, your chiropractor, your acupuncturist, your herbalist. People like to have a variety of options available, and plants in various forms can find a home in all of those places. And ultimately, yes, plants should not be, that people have been producing for a long time. You should not stop anybody from cultivating plants. The only botanical bands that I think are worth entertaining are the ones that you can produce ricin out of biotoxins or bioterrorism agents, and endangered species like the Salt Creek tiger beetle or some African violets or some. These are some plants and substances that you may want to be careful.
Well, now, what would you say is the ultimate goal? Is it to have everybody be able to have a marijuana plant in their kitchen on the windowsill, or is it to have pharmaceutical companies control it?
Oh no, nobody should be monopolizing cannabis. It is a Commonwealth plant, but I would like to see that people are able to develop their own local systems of medicine around this, as people have been doing for a long time. It's a way to empower people. It's a way to have local production of medicine as opposed to having to buy it from some faraway company when you can make it locally. You can have strain seed banks and strain sharing and knowledge sharing, and at the same time you can have pharmaceutical companies want to develop these medicines. They should be freely licensed to be able to do so. So if you want to go to your Rite Aid versus your local herbalist versus your own kitchen garden, should be all available. But I think doctors and patients have a role to help guide and instruct, and in the setting of other medicines, how this will interact, and to help also educate about disease modification. Maybe you didn't know that cannabis could potentially be helpful in Parkinson's or Alzheimer's.
Oh, Dr. Sunil, we only got a couple of minutes. Dr. Sunil Aggarwal.
Agarwal, yeah.
Agarwal, right. Dr. Sunil Aggarwal is joining us. And Dr. Agarwal, I wanted to give you the last minute or two just to tell us how you got into this.
Yes, it's a kind of serendipitous situation. I was going to college in Berkeley, California, in the late '90s, early 2000s. I was working in a lab at UC San Francisco, and in chemical neurobiology. I was so into brain and chemistry and mind body. So I was walking back to my house, and I saw a symposium going on in my big main biology building in Berkeley, in the main auditorium, called DARE, Marijuana, What DARE Didn't Teach You. It was put on by this new group called Students for Sensible Drug Policy. I was very intrigued by this, and it was happening in the auditorium that took all my biochemistry classes, all my science classes in. So I wandered in, and I saw this professor drawing these chemical structures on the board of cannabinoids and cannabis, and talked about this endogenous system, and he said that this is a very unique neurotransmitter in the body which we've never discovered because it goes backwards. It's the only system in the body that we know that robustly goes backwards across synapses. That is to say, people talk about neuron A talking to neuron B, like dopamine, serotonin, adrenaline. But cannabinoids go backwards, and I was very intrigued by this feedback system, and I just started reading all about it and went to meet the actual scientist who was working a few floors up from me, who had actually discovered that feedback system.
Dr. Agarwal, half a minute. How can people learn more about it? Do you have a website?
Your viewers could go to cannabinergy.com. That's CANNABINERGY.com, or you can find me on Facebook. Sunil Aggarwal, Kumar Agarwal, MD, PhD. I have a physician page there, and you can...
2 Gs.
Yes. You can read more, and you can always email me at sunila@uw.edu, and I'd be happy to answer any questions or put you in touch. If there's a physician or care provider, we need people to help lobby around the New York State to let us have a medical cannabis law like New Jersey has, so we can bring this relief to our patients. And
Thank you, Dr. Agarwal.
All right.